This video is about the transformation of the AZV, moving from disease care to healthcare. This involves a strategic, legal, and financial blueprint for integrating prevention and elderly care into the national general health insurance. Aruba's healthcare is at a turning point due to a demographic and financial crisis driven by chronic diseases and an aging population. The current system compensates for curative care but excludes systematic prevention, leading to high costs. The foundation of 1996 is contrasted with the reality of 2024. The aging segment of 65 plus is growing, resulting in complex care costs. The care demand shifts from acute infections to chronic diseases, while financing remains reactive. The system flaw is that the law covers consequences, but not causes. Curative care is fully covered, but preventative gaps remain, with limited coverage for general health checks, dental care, and preventative physiotherapy. The AZV functions primarily as damage insurance. Demographic pressure and the shift in care responsibility are significant. Indicator 1 shows accelerated aging, leading to an exponential cost increase. Indicator 2 highlights migration and culture impacting care logistics, leading to an urgent need for professional elderly care. The new paradigm shifts from reactive disease care to proactive health care. The focus moves from treating advanced diseases to early detection and prevention. Financing should reward health outcomes, and the general practitioner becomes the primary care center. Pillar 1 focuses on anchoring prevention as a legal right. This includes integrating preventive oral and eye care, mental health coverage, and structural screening for early detection. Also, a full compensation for recommended immunizations is included. The health defense model adopts the 3 lines of defense principle. The first line is primary prevention, focused on health education. The second line is secondary prevention, with early interventions and structural population research. The third line is tertiary prevention, focused on damage limitation and specialized chronic management. The legal architecture of the reform includes amendment of the National General Health Insurance Law to explicitly include preventative services. It establishes a, quote, preventative care regulatory body for quality and oversight, and mandates secure data exchange via electronic patient records. It also ensures access and non-discrimination. The patient journey illustrates the ROI of early intervention. The current reactive model leads to costly escalation from undetected hypertension to expensive ICU stays. The reformed proactive model detects risk early, allowing lifestyle interventions and light medication, minimizing costs and keeping the patient active. The financial transition involves investing to protect the multi-year financial framework. A dedicated prevention fund is created by structurally reallocating curative savings. This is supported by provider incentives and risk-sharing models, rewarding providers for achieving prevention goals. Primary care acts as the foundation and gatekeeper. The enhanced general practitioner moves to a proactive health manager role, supported by specialized training and equipped practices for local screening. Interdisciplinary cooperation is seamless, supported by the AZV database and electronic patient dossier. Health extends beyond the clinic through societal integration. Schools serve as the basis for health education and structured screenings. The workplace introduces wellness initiatives and on-site screenings. Mobile care units offer outreach to vulnerable, remote communities and the elderly. AI and digital care act as a catalyst for scalability. Predictive analysis uses AI to forecast trends and intervene proactively in high-risk patients. Automated diagnostics enhance the speed and accuracy of population screening. Telemedicine and natural language processing support preventative counseling and follow-up. Measurable success is managed through a monitoring and evaluation framework, utilizing transparent KPIs, data-driven policy for real-time steering, and mandatory independent audits. The goals are increased vaccination and screening coverage, a 20% reduction in NCD incidence, and a 30% drop in tertiary admissions. Prevention is a shared responsibility among all stakeholders in Aruba. The government creates the legal framework, while health insurers finance prevention and reward outcomes. Citizens take personal responsibility and participate actively in programs. The core message is that maintaining the current system leads to rising costs and declining public health. Integrating preventative care and structured elderly care is the only viable economic and social strategy to secure the foundation of universal healthcare for future generations. The action plan for 2024 to 2025 has 3 steps. Step 1 is the legal framework. Step 2 is infrastructure and pilot programs. Step 3 is scaling up and establishing a monitoring and evaluation framework.